Greetings, everybody. Hey, there's Nick. Are you coming in the panel, Nick? You gotta wear your shirt, Nick, if you moderate. There's Abby. Okay, there's Atul.
Hi, John.
Hey, Atul, how you doing?
Oh, very well, John. You're looking very fresh and fit.
The king is back. You haven't been here for a couple of months, right?
Yeah. Just jumping around, my dear John, here and there.
Well, we'll fix that. Have you been traveling?
Too much.
Too much,
And-
okay.
And today I'm a little bit, respiratory infection today.
Oh, okay.
So a little bit down.
King of webinar. Okay, Yandong Su.
Yes.
There's a few people that want to say hi to you. Let's see, Nick is here. You know Nick.
Yes.
So yeah, do you use the exoscope for Dr. Goel?
Not so much. I have it, but I'm not good. I have not used it too often.
Well, I'd like you to meet Yangdong. Yangdong Su, I think he wants to meet. How you doing, Yangdong? You're from China, right? Yangdong?
Yes.
there?
He's
Yeah.
from Shanghai. He's my, he's
Yes.
the
Oh,
king
you know
of
him. He's your man in China, right?
Yes. I'm king of audience.
he's king of
Thank you.
audience.
Oh, okay.
Good partner of king of webinar.
Yes. How are you, my dear friend?
I'm very fine. Thank you, Professor.
Very good.
Yeah.
Welcome, Takashi.
Good evening, Dr. Goel. So I'm very interested. I finished my meeting, so I have a little bit relieved.
Okay.
Enjoy your lecture. Thank you.
Okay, Takashi. Thank you for coming.
Okay, you want to get started, Dr. Goel?
Yeah.
Okay, here we go. Let's see, hold on, let me get, make sure we got everything right here. Yandong, you want to introduce Dr. Goel? You could moderate if you want.
Hello, dear John.
Do you want to moderate, Yandong?
Yes.
Mm.
Dr. Yangdong will moderate the session.
Okay, I'll introduce
Okay.
him.
Thank you.
Okay, and I'm going to introduce you, and you introduce the king. Okay,
Okay.
not the
thank you.
pretender, the real king. Okay, 10, 9, 8, 7, 6, 5, 3, 2.
यार देखो ये आवाज नहीं आ रही इसमें
Hold on. Let me take
आवाज
care
क्यों
of
नहीं आ
that.
रही मुझे
Let me take care of that noise first.
इसमें पहले ही चल
Hold on. Okay, let me get the title right. Hold on.
रही बात
Okay,
करते
here we go. Okay, everyone mute themselves, please. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning. This is Dr. John Bennett broadcasting from beautiful Miami Beach. We have the honor of having the king of Zoom, a gentleman that travels all over the world spreading neurosurgery and specifically spine education. And he's on the second issue of the Revolution of the Spine series. And we're going to have a friend of his introduce him, Yandong Su. Good day, Yandong.
Okay, thank you. So today we are very honored to have our Taiwanese educator, King of Webinar, Professor Atul Goel from India, to have his second episode of Evolution of Spinal Surgery. So I think we do not need much words to introduce our our educators. So I think Professor Goel, please.
Okay, thank you very much, my dear Yang Dong. And I just want to share my screen. So today I am going to talk on some anatomical issues, anatomy of craniovertebral junction, and particularly anatomy of atlantoaxial fixation technique. So that is my title. And as we know, anatomy is so crucial and critical in all neurosurgery and spine surgery, and particularly in this area where if you do it properly, you give new life to the person. And if you do not do it properly, you can actually do great harm to the person. So we have to know this subject very, very fantastically and beautifully. You cannot do this atlantoaxial fixation without having a mastery of anatomy, without having mastery of blood control, bleeding control, mastery of instrumentation, how to handle the screws, how to handle the instrumentation. You have to have very big mastery of handling these instruments. So today I am going to discuss anatomy of atlantoaxial fixation. So this is the beautiful head and brain, and this is the brain stem, and it is this craniovertebral junction is the most protected, has a beautifully protected environment in the skull. It is the seat of mobility. The head moves in this region. The seat of stability, the whole head is stable. You know, on your shoulders, it is stability and mobility and also safety. All the neural structures have to traverse safely. All the vascular structures have to travel safely whilst the head is moving rapidly in this area. So safety, mobility, and stability. So these are the three king features in the craniovertebral junction. And I've shown this kind of slide on several occasions. So this is the human spine. And if you see this pillar, there is a bifurcation of this pillar. So this pillar actually holds the roof like this. So there is a bifurcation of the pillar on the topmost part of the pillar. And this bifurcation is the craniovertebral junction. And this craniovertebral junction has two very important joints. One is occipitoaxial joint and atlantoaxial joint. Occipitoatlantal and atlantoaxial. Occipitoatlantal is the joint, is the most stable joint of the whole body. And atlantoaxial joint is the most mobile joint of the body. So stability and mobility are on these two joints. And this is the occipital bone and this is the foramen magnum. And there are two occipital condyles in the edge of the foramen magnum. And this is the beauty of the C1, C2 bone. This is the most unusual or different kind of spinal vertebra. This is C1 and this is C2. This is the arch of atlas. These are the facets of atlas. This is the transverse process. This is the spinous process of C2. So if we realize the transverse process of the C1 is the largest transverse process of the whole spine, and the muscles attached to the transverse process help in the rotation of the neck. C2 spinous process is the largest spinous process of the whole spine, C2 spinous process. And this C2 spinous process caters to all the muscles which are involved in flexion and extension of the neck. Extension of the neck, not in flexion of the neck. The C1 facet, the upper part, which is in alignment to the occipital condyle, is the largest facet in the whole spine. So you see there are too many largest in the C1, C2, and this caters to the largest amount of movements in the spine. C1, C2 joint is the most mobile joint of the body. And if you see the muscles of the spine, all the muscles of the spine, if you see this picture, are located in the back of the spine, in the back of the neck. And these and very few muscles are situated in the location of the vertebral body and disc. All the muscles are behind, because human body is a standing position, and extensor muscles of the spine are the predominant muscles of the spine. Flexion movement is a passive movement. Extension is an active movement. All the muscles of the back of the spine are focused on the facets, and the facets forms the fulcrum of all movements. So this is what we have to remember. Not many muscles are located in the front, in the vicinity of the vertebral body or in the vicinity of the disc, not many muscles. So as I had discussed in my earlier presentation, disc is like air in your car. It helps the movements, but the petrol and the machine is this muscle. And this muscle acts on the piston is the facet. So the disc has a different role of air in your car. If there is no air in your car, in your tires, the car cannot run. If there is no air in your tires in the plane cannot land on the ground. But the machine and the fulcrum of movement and the piston of movement is run by the muscles and is based on the facets. And if you see the neck, this neck has huge, very solid muscles in the nape of the neck, solid. And these muscles are involved in flexion, extension, rotation, and all these movements, these muscles take part. And you see, this is C1 arch, C2 spinous process. These two form there is not many muscles are attached on the arch of atlas. All the muscles, major muscles, are attached to the transverse process of atlas, and they involve in rotation. And these large muscles, which are attached to C2 spinous process, are involved in flexion extension movements. So we must remember that these muscles are very important. When we are doing C1, C2 fixation, we should remember that these are strong muscles. You cannot ignore these muscles, and I will talk about it later. And when you are doing dissection from the mouth, you put your finger in the mouth and you can touch the vertebral body. You can actually touch the anterior arch of the atlas, and you can touch odontoid process. So there are not many muscles attached to the anterior surface of the vertebral body. So if you take an incision in the mucosa, you land directly on the anterior arch of the atlas and on the odontoid process and C2 body. So that is the difference. The difference is, it is not a difficult procedure to come from front and to see the odontoid process, but I will talk about it later. The vertebral artery has a very unique course in the C1, C2 area. It comes in the transverse process of the vertebra, transverse process. It goes up, it goes up, it goes up, and then it turns medially. Then it turns medially towards the facet and the pedicle. And then it turns and rotates, and then it goes out of the transverse process of C2. Let me show you some other slide. So you see here, this artery is going up, 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 and then it goes medially, and then it turns. It turns like this and goes in the arch of Atlas like this. So this medial turn of the artery, of course, this is too much. It does not happen so much. This is an unusual specimen that we got when the vertebral artery was very high riding. And you see the C1, C2 articulation. So it is very close to the articulation. Normally, it is not so much close. You see, it is going right up to the body. But this is the course which is unusual course of the vertebral artery. Another very beautiful thing is, you see, this is the vertebral artery groove, and this is the vertebral artery. So we said in this article of mine that vertebral artery has a dynamic course. So when you move your neck like this artery goes up and down, goes up and down like this. You move your neck like this, the artery goes up and down. So if you see a vertebral artery groove on the imaging, it may be that half the groove is not occupied by the artery in a particular position. Or the whole artery, if you turn the neck, the artery may be occupied by the groove. So this groove has a dynamic kind of relationship. Vertebral artery moves during the neck movement. So in neurosurgery and in spine surgery, as we know, about 35 years ago, at least, what are screws? Neurosurgery was, we didn't know what are screws. We didn't know what are facets. We talked about brain, we talked about disc, we talked of canal stenosis. We didn't know what facets are 35, 40 years ago. We knew atlantoaxial instability, but we were not very familiar as to how to treat atlantoaxial. And there were disasters, post-operative mortality and morbidity and ventilator. We all know that. So it is important to know about the strength of the facets. Facets are critical. It is form the fulcrum of the spinous, the fulcrum of the movements of the spine. They are the machine. They are the whole muscle bulk is focused on the facets. So facetal fixation, if you can control the point of fulcrum of movements, that is the best form of fixation. So in 1987, about 36 years ago, we described this technique, 36. You can imagine at that time what were plates and what were screws, and even in the lumbar spine, they had just been introduced at that time. And Steffi and all those people were very popular because they had introduced for lumbar, for posterior lumbar interbody fusion and use of screws and rods, and rods were not popular at that time, but plates. So we described this technique of one screw in C1 facet and one screw in C2 pars pedicle facet. That technique we described, and my first case was in 1987. Of course, you know that this technique is now a very popularly used technique. This was my first case in 1987, where we did for mobile atlantoaxial fixation. You see there is C1, C2, there is bone formation here. Occipital bone is not included in the fixation. Subsequently, over the years, we have treated several hundred several thousand patients, 3,500 or 700 patients with such C1, C2 fixation. And I have no hesitation to say that we have given so many new lives to the patient. If you can do this technique, you give new life instantly to the patient, and the patient will live happily thereafter. On the other hand, you do incomplete operation, suboptimal operation, you can actually damage the person very badly. So this technique of one screw in C2, one screw in C1 has to be learned and has to be learned very nicely. And we have done in 3 months old child. This is a very small little child we did. And we did, this is another very small little infant that we did. So you have to do in small children, in big adults and old. 88 year was my maximum. But atlantoaxial fixation can happen anytime. In the infants and in young children, they may happen the injury to the muscles of the neck, which control the movement. My recent concept is atlantoaxial instability is never congenital, is never due to embryological dysgenesis or error in embryogenesis. It is always a result of injury to the large muscles of the nape of neck. It is never a congenital error. So that is one beautiful thing that I have realized. And this injury can occur inside the fetus or in early post-delivery situation. So we have done several of these fixations for various kinds, and we have given tremendous new lives over the years, and there is no question. So the facets of atlas and facet of axis are the largest and strongest in the body. So if you are able to put a screw in the facet, firm and strong screw in the facet, provide a very beautiful purchase for the screws. And you can put a solid screw in the facet. There is no other bone of the spinal vertebra which is as strong as the facet. Pedicle is not as strong. Transverse process is not strong. Body is not strong at all. What is strong is the facet. And these are very strong bones. And if you can put your screw in the facet, sorry for that, and you can have a very strong fixation. So my technique since the beginning, since 1987, involves some basic 3 steps. Opening of the joint, removal of the cartilage, putting bone graft in the joint, and then doing C1, C2 fixation. So these are my steps. And the next step, which is absolutely important, is when you are doing atlantoaxial stabilization. And if you leave the muscles of the C2 spinous process, which are very, very strong, they can pull up any implant. They can break the implant. So once you do your fixation, you have to cut all these muscles attached to the C2 spinous process. That is why I say, if you are doing anterior fixation and you are leaving the muscles attached to the C2 spinous process, this C2 spinous process muscles are so strong that they can pull up any implant. So after surgery, after you have done your instrumentation, you cut all the muscles attached to the C2 spinous process and the arch of atlas, drill the cortex, put lot of bone graft. Bone graft will be inside the joint. Bone graft will be outside in the posterior element. So solid arthrodesis is the aim of operation. We also discussed this alternative method, one screw in C1 and one screw transarticular, Megel's technique. We all know Megel's technique. So you can have a double insurance kind of, I use it sometimes, but it is not really mandatory because the facets are so strong. But sometimes in high riding vertebral artery, you cannot use the appropriate trajectory. You see here in this, there is a high riding vertebral artery. So if you put like this, you can damage. So this operation was done maybe 25 years ago. Now I have other techniques to avoid the high riding vertebral artery. So this is another case where I have done double insurance fixation. The other thing that I used to do, and I don't do now, is transoral decompression. And I was very big master of transoral decompression, and I had done several hundred transoral surgery during those days. And this was a very commonly done operation and very popular operation, transoral decompression. Now, many of you know that this word compression and this word decompression, I have completely removed from my neurosurgery. And as we go further in our series, I will talk more about it. We also had experience, for this kind of basilar invagination, I removed the whole of the odontoid and C2 body and put iliac crest bone graft. We used to do, and I was very, very conversant with this anterior transoral surgery. I also used screws and plate from the retropharyngeal space. So this is C2-3 at that time, and I had done this kind of fixation. But I can tell you now that this was a wrong operation. When there is C2-3 fusion and cripple file abnormality, you have to do C1, C2 fixation, not C2-3 fixation. Even when there is a compression here, you have to ignore this compression. This is atlantoaxial instability. You don't have to do C2-3 fusion. This is actually C3. This C2-3 is fused here. This is C3-4 fixation. I also used transoral decompression and transoral plating long ago, about 30 years ago. See, remove the odontoid process and do a plating from clivus to C3. So this kind of plate we described and we used it. This is another, in 1992, I did this, removed this odontoid process and did this fixation. And now I will say that this C2-3 fixation needs C1, C2 fixation and nothing else. So as I mentioned, transoral surgery is completely out of my picture. Transoral surgery is not required. It is, you introduce implant by retropharyngeal or transoral surgery. The posterior muscles can pull that implant and break that implant, and it will never be stable. The other thing I used to do was occipital fixation, initially during wires, and then we describe screws for the occipital bone. These screws we described for the first time in the literature. So these occipital screws, screw in C1 and screw in C2, this I described 30 years ago. So this kind of occipitocervical fixation, which many people do, I was very familiar and I was doing that method. And we described this occipital screws. And these were described first in the literature. But now I can tell you with great, authority that occipital bone inclusion in craniovertebral junction stabilization is not necessary. It is a suboptimal form of fixation. Of course, if you cannot do C1, C2, if you cannot expose the facet, if you cannot put a screw directly in C1, then you have to use occipital bone as a salvage technique, not as a primary technique. In my estimation, inclusion of the occipital bone is not necessary and may even be counter-effective in craniovertebral junction stabilization. Now, when you do C1, C2 fixation, there are 2-3 things which are very important. One is you have to stabilize the head during surgery. So this is my position, head high under traction. Head high in neutral position. I don't give any flexion or extension. And this head high position reduces the venous congestion in this area, and it is in direct line of your surgery. So this is my position under traction. Another beautiful term that I had introduced was floating head. So head, actually the head is on the traction. It does not even touch the headrest. And this venous bleeding is so important to control because there can be furious venous bleeding during surgery. Now I want to show you the anatomical issues in the facets of atlas. You see, this is the facet of atlas, the upper part, the rostral part towards the condyle. And you see how many, this is very big. And also there are attachment of several strong ligaments. You see strong ligamentous attachment. On the other hand, this is the undersurface of the facet towards the atlantoaxial, towards the atlas. And you see it is round and flat. This is the upper surface and this is the undersurface. And if you realize there are not many muscles attached here. So this is the C1 facet. This is huge, which is approximating to the condyle, and this is round and flat. This is the most stable joint. This is the most mobile joint. When it is mobile, it is more likely to become unstable. So atlantoaxial joint is the most unstable joint of the body. Occipito-atlantal joint is the most stable joint of the body. Craniovertebral junction instability means atlantoaxial instability. Very important statement. Craniovertebral junction instability means atlantoaxial instability. Craniovertebral junction stabilization means atlantoaxial stabilization. Very, very rarely you can have occipito-atlantal instability. And that is under extreme degree of trauma and very rare. I have never seen occipito-atlantal instability. Now, another magical and beautiful bone is C2 vertebra. One is there is an odontoid process. And the second beautiful thing is the facets. You see the facet. This is the rostral or upper facet. And this is the inferior or the lower facet. They are not in one line. All the other facets of the spine are one above the other in one line. But here, the superior facet is in front and the inferior facet is behind. And the vertebral artery goes like this here and then turns and then comes out here. This part, superior facet, is more in proximity to the vertebral artery. So vertebral artery goes here like this and then turns and here and then comes out here from this transverse process. So when you do a C2 screw, you can hit this loop of the vertebral artery. And that is very important. In my last lecture, I had said that this odontoid process is an absolutely magical bone. It is a divine bone. The function of odontoid process is like the function of the disc. It is the brain of the movements of the C1, C2 brain. And you have to, if you have not heard my previous lecture, maybe you can hear the recording of that. How the odontoid process is the brain of movement. And the anatomical or the mechanical structure of C1, C2 bones, they make the entire machine work. So the C2 superior facet, C2 inferior facet. Now you remember this alignment of the superior facet and inferior facet. I will talk more about it. And the other beautiful thing is a huge spinous process, the largest spinous process of the whole spine, and the big bulk of muscles are attached to the C2 spinous process. And this is the vertebral artery, and this forms the major issue in C1, C2 fixation. So few years ago, we described this radiological revolution, investigational revolution for craniovertebral junction surgery, 3D models. You can make models where you can show the vertebral artery. Let me show you. So this is a model. This is a 3D scan, but this is a model. You can hold it in your hand. And when you hold it in your hand, you can take this model in the operation theater and you see where exactly is the pedicle, where exactly is the facet, where exactly is the vertebral artery coming out, and you can identify a beautiful place to insert your screw. So these 3D models, which we designed, were very, very useful for at least for complex cases. And you see this here, a model, and we did this C1, C2 fixation. This is another model. You see here, this is quite a case, C1, C2 facet. Another thing which you can see here, there is assimilation of atlas, whether it is assimilation or not assimilation. I do not use occipital fixation. I use C1, C2 fixation. I use this huge facet for introduction of the screws, and these models can make your life very simple. Most important is to direct your screw in a particular direction. You cannot direct the screw. You see, this is probably, this is not, this is up and medial. C1 facet, you can just direct in the center of the facet. C2 screw up and medial. This is very, very critical. If you go down, you can hit the vertebral artery. Of course, there are some anatomical situations where you have to go down. Medially and superiorly, superior and medial, that is the direction for the C2 screws. And if you damage the vertebral artery, this was another very complex case. You see the very high riding vertebral artery, and I damaged the vertebral artery. And there is a huge occipital infarct, and this patient became blind after surgery, and his blindness has never recovered. I am not saying vertebral artery damage is very, very dangerous. I must have damaged vertebral artery on several occasions. But this is one occasion where the person had gross visual deficit, and there are few occasions where the person actually died following surgery. But basically, vertebral artery damage, if it is damaged, you rapidly tighten the screw, or you just ligate or sacrifice the vertebral artery quickly, because there are two vertebral arteries and there are other arteries in the brain. Damage to the circulation is hardly there. So you don't worry about vertebral artery all the time. Of course, you have to be careful, because such a massive visual deficit can be devastating. Other thing I want to show you is the OPLL. OPLL in any situation is related to an unstable spinal. I will talk of OPLL later in my series. This is another case where I had damaged the vertebral artery and there was occipital infarct. This patient recovered in very quickly. So if you have to divide this area for vertebral artery, one is you have to see coronal image for the vertebral artery course and high riding vertebral artery. And if you make these 9 quadrants, this upper and medial are the best quadrants to introduce your screw. You can use navigation, and I used to use navigation, but it is not highly mandatory. For last several years, I have not used any navigation during surgery. If you see this case, the vertebral artery is here, and this navigation is helping you introduce your screw. I don't use navigation now. Other very fantastic thing that we described when we started this procedure was this C2 ganglion. This C2 ganglion is right behind the C1, C2 articulation. So first time in the literature we said, and this was the complete revolution at that time probably. You cut the ganglion and you expose the C1, C2 articulation. And we said that it is very safe to cut this ganglion and you get a very big exposure. Now I say I don't use it often, I use it very rarely, but this possibility of cutting it makes the exposure, and to know that there is a ganglion, this was this anatomy was not very well understood at that time. So this is C2 ganglion. Ganglion here, you cut the ganglion and you expose the joint. Vertebral artery is lateral. Your screw has to be here. Your screw has to be here. And vertebral artery has a dynamic course. We should remember this. And these 3D models, and there can be various anomalies of the vertebral artery. You see this artery, this is spinous process coming out and going medially, posterior to the C1 facet. So you can have a very big danger if you don't know this anatomical situation. This is the facet of C1, facet of C2, facet of C1, bifid. This anatomical information, 3D models make your life very, very fantastic. Another entity you might not have heard because it is quite a rare anomaly, bifid C2. Bifid C2 posterior elements, and we had said that bifid C2 is also indicator of C1 C2 instability. So when you see bifid, there is C1 C2 instability. This is another case of very gross vertebral artery location. This is another, you see how it is going posterior to the facet of C1, and this is another going posterior to the facet of C1. Then we had introduced these intra-articular spacers for C1, C2 fixation. In 2004, I did my first case. In 2000, I did my first case, and we introduced this joint jamming technique or for distraction and spacers. I must say I don't use spacers too often now. These were the spacers. They give solidity to fixation. They distract and reduce, and they assist in arthrodesis. But now, instead of spacers, I like to put a lot of bone graft. More than spacers, I realize I rely more on bone graft. So this is another 3D model, and I did this spacer and did C1, C2 fixation. We also used standalone spacers without any other implant. No plate and screw, standalone. I don't do these kind of things now. This is another standalone spacer. There is space for bone graft. Now, if you read this article of mine where I have said when to use spacers and when not to use spacers, I must say that now the use of spacers in my series is very, very less. Also, we describe for the first time in this literature, laminar screws. We also describe spinous process screws. We also describe spinolaminar screws, and these were all published much before any other technique was described. So if you are not able to do this kind of C1, C2 fixation on both the sides, you can use spinous process, you can use lamina, but basically this is the best technique. If you cannot, then occipitocervical and all those things are salvage techniques and suboptimal techniques. So when we are doing C1, C2 fixation, you have to use the best technique. Why you have to use suboptimal technique? You have to use best technique because if the patient has to improve, he will improve with the best technique. So I used to do 30 years ago, these kind of spinous process screws, spinolaminar screws. Another beautiful thing that I think this is a fantastic technique. I told you that the C2 facet, the superior facet is in front and inferior facet is behind. C2 superior facet is in the vicinity of the vertebral artery. Sometimes vertebral artery is very high and you cannot put your C2 screw in the C2 superior facet. So you can use the inferior facet rather than laminar screws. You can use the inferior facet. See this inferior facetal screw. Also, you can use C2-3 transarticular screws, which are very, very strong. So C2 inferior facet screw or C2-3 screws. So here you see there is a big problem in this area. I was not getting the right bone, and I have put a screw in the inferior facet of C2. I think this is a very safe, because vertebral artery is not in the vicinity of the inferior facet. You put this kind of screw, and this is a very, very solid fixation. Of course, C2 superior facet is the best, and these are salvage techniques. So very high vertebral artery, and this is inferior facetal screw. So this is what we must remember, that in case of a problem, you can use such screws. The other technique that we described was mobilization of vertebral artery. So if the vertebral artery is high, you can drill, this bone becomes very thin, you can drill over it using diamond burr, and then you can push the vertebral artery. So this technique of mobilization, and then you can introduce the screw. And we have done on several occasions such a. So this is very high vertebral artery. So what we have done is we have mobilized the vertebral artery. You see the vertebral artery mobilized, and then we had put a screw. So let me show you the technique now, okay? Wait. So this is a 10-year-old girl who had a blunt injury, and these are the radiological imaging. Oh, sorry for that. So these are the images. It is not running somehow. Yeah. And you see the high riding vertebral artery here. This high riding vertebral artery on both sides, actually, both sides. And this, this is my position. Now, let me show you. This is the C2 spinous process. I hope you can see that. This is the lamina. And along the lamina, and you see the red color, there is no black color, there is no coagulation in this operation. And you see how unstable it is. And then I put a small osteotome or a chisel inside the articulation. Then I expose the C1 facet. This is the C1 facet. You see how unstable it is. I have told you that if you can do a good solid fixation, you give new life to the person. And such new life, I had opportunities on several occasions in my lifetime. And I'm so proud that I could help these unfortunate people. And I no longer call them unfortunate now, because they are now fortunate and they are leading good, beautiful lives. So here I have opened the articulation. You see how much it is mobile. Hugely mobile. Mobilize the joint. I am putting this guide hole in the facet of C1. Sometimes I do this operation in 20 minutes. Sometimes it may take some long time. And sometimes, we are human beings. You can have problems here and problems there. But this is a fantastic. I like to use these plates even now, because I have a feeling that these plates are directly on the facets, and they make the whole procedure biomechanically very strong. So here, if you realize, here is now I am making a guide hole in the C2. After seeing the vertebral, you see the pulsations of the vertebral artery. I am introducing a hole in the C2 pedicle and the facet. you have to get a control or hang of the venous bleeding. You have to get the hang of the vertebral artery. And as I repeatedly mentioned that C1, C2 fixation is such an important operation in spine. The indications are increasing rapidly. Now I do C1, C2 fixation even in cervical degeneration, in OPLL, in Hirayama disease. So the indications are increasing, and you see, you can tighten the screws over the plate, which is procedure which is not possible when you're using rods and all. But of course, rods are similar. There is only the change of the name, polyaxial from monoaxial. Now I want to show you the right side where I mobilize the vertebral artery. I'm not sure if I will be able to show you properly, but I hope I can show you. So the vertebral artery groove is here. You see here the pulsation of the vertebral artery. You can see, I'm not sure if you can see, but see the pulsations of the vertebral artery. First, I enter into the joint. Then make a guide hole in the C1. Here is the vertebral artery. I'm trying to little bit move the vertebral artery. Then, of course, I will drill and move it much more. First, I'm putting the C1 screw. Putting bone graft in the facetal articulation. Very important step. If you do not do this, I have a feeling that, this is what it adds to the stability by itself. It makes the whole area very much stable. Then you see the hole in the C1 facet. You can take the hole, and if you realize the ganglion has been displaced upwards. Now you see I will be mobilizing the vertebral artery in this case. You can use the drills or you can use the diamond burr. Here I'm using a small little ronger to get to the vertebral artery. And sometimes you can do it, diamond burrs are the best here to expose the vertebral artery widely. We have to avoid using cutting burrs because they can sometimes get the vertebral artery. So as I mentioned, that vertebral artery damage is a possibility. But the complications following vertebral artery injury are very rare. So we should not just think about we have to think about vertebral artery, all right. But we cannot be too much scared about the vertebral artery. We have to learn the vertebral artery. We have to tame the vertebral artery. This, you see here now with this dissector, I am retracting the vertebral artery downwards. You see this here? It's a difficult procedure already. You see how the vertebral artery is in my picture. I'm pushing the vertebral artery down and then making a guide hole. Of course, this is very rare. You don't have to do such maneuvers and you don't need to do so. This is, I'm making this operation look very difficult, but this kind of situation is extremely rarely necessary. Don't get, into this situation or think too much about this. This is an absolutely rare kind of situation. But basically the thing is that you have to know the vertebral artery, you have to handle the vertebral artery, you have to tame the vertebral artery and deal with the vertebral artery. So here the vertebral artery was mobilized, and then the fixation was completed. Now, another thing which I want to show you now is how, you have to cut the muscles of the C2 spinous process. And this is the beauty when you are doing from behind. I have done several cases from front, but never this kind of stabilization, this kind of solidity can never be obtained by any other technique. See, now I am drilling the posterior elements of C1 and C2 just to decorticate them very effectively and widely. C2 spinous process has to be cut. Now I could not, this was an edited C2 spinous process, C2 lamina, and you see large amount of bone graft has been put, and this is the stabilization. Another last technique which I'm going to show you is about C1 screw. Sometimes it can be, so you can use transcranial insertion of atlas facetal screws. You see here, there is assimilation of atlas. You can, of course, use occipital fixation, but as I have told you, that this solid bone, if you can put your screw in this solid C1 bone, it is nothing like that. This is very thin and it may not be stable. So I remove this occipital bone and then expose. So transcranial, extradural transcranial, or get to the facet. So this is another difficult process where I did a transcranial insert. So that is the position, my dear friends, and I hope I've been able to give you some beautiful thoughts on craniovertebral junction stabilization. And I want all the young people listening to me, all the senior people listening to me, to learn this technique. And my dear Yang Dong, who is listening to me, I'm sure he will get opportunities, many more in China, and he will become a master of C1, C2 fixation in the coming future. So thank you very much, my dear friends. And if there are any questions, I'll be happy to answer. Yang Dong, conduct the show.
You're muted, Yandong.
Harshad is there, Harshad?
Unmute
Yes,
yourself.
Atul.
Harshad?
You know how to demolish
Yes.
everybody. Even though you don't seem to be well, but you have given a wonderful anatomical demonstration with surgical demonstration of C1, C2 fixation. Wonderful, wonderful. Today's
you.
lecture was really, really learning from everybody. If anyone says I've not learned anything, means he has not listened to your lecture. Every time I listen to you, I learn something. I also do C1, C2, and I know what happens and how it happens. When it comes to bleeding, I always tell Atul can see through the bleeding. He can see through the bleeding. Where is the vertebral artery? Where is the C1, C2? He lives into that. The bleeding doesn't bother you. And I've seen you putting screws through that, and wonderful, wonderful technique. And superb. There is no second thought
Thank
about
you.
you have taught us
Thank you, Harshad.
many things.
Thank
Wonderful,
you.
wonderful.
Thank you. Now I can see Mohammed on the screen. Mohammed, you are there? Mohammed?
Hello, hello.
Yes, yes. Where are you? You look in a very comfortable situation.
Yes,
Where are
yes.
you?
I'm enjoying. I'm at home with my family and still enjoying your talk and your lectures.
Very good.
Uh,
So,
I do have one question.
yes.
Because you are always in front of us like 1,000 miles, so maybe you have invented, or I would say it like a new indication for C1, C2 during this time.
Yeah.
Is there any new idea or new indication?
So, this, I am going to give 20 lectures in this series. So the indications will come.
Yeah,
So
yeah,
you
I'm
just
following
wait.
that.
Just wait and watch. Okay?
Okay, I'm waiting.
Okay. Okay. Thank you. Now I want Yang Dong, you want to say something?
Yes, I have some words to say here. I think it's unbelievable for anyone to believe that this C1C2 fixation technique was proposed by Professor Goel at his last year of residence. And you can know image the C1C2 fixation can be finished within 45 minutes from skin to skin, including eye crest, grab hapsting, and even you cannot believe petroclub meningioma of 4 to 5 centimeters can be resected by a beautiful supracerebral approach within 1 hour from skin to dural closure. But all this happened in Professor Goel's hand. I always then I think for young neurosurgeons it's very important to have all these concepts, all these beautiful concepts in your mind before you have your surgery independently. So I want to thank you. I want to thank Professor Goel again. Thanks for your beautiful concepts. Thank you.
Thank you. Thank you. Nicholas, you want to say something?
Good evening from Thessaloniki, Greece. It is a great pleasure to listen Professor Goel as always. We're waiting to see you in real life in World Spine Column Society in Athens last November, but the visa problems obeys you to come.
Yes.
Professor Goel, every time that I listen I learn something new. And this is a very important step in order to understand the anatomy of the cervical spine, the physiology of the cervical spine, and then to analyze the pathology and perhaps to find some solution in the problems, traumatic, the degenerative that our patients has. One small comment only about the impact of the age. How I'm sure that you will analyze these things in the next lectures. The impact of the age, especially in the generation, this is an important step because also in the United States and also here in Europe, because the people are getting older and older, and many times we have to face older people. Only a small comment. Thank you very much, and we are learning from your lectures. We are learning from your your papers, and we are very grateful. Thank you very much. With true friendship that you know that I have to your.
Thank you, Nicholas. So nice of you. You see, I have done C1, C2 fixation in a 3-month-old child, and also my maximum was 87-year-old man. So in the young children, the articular cartilage is very smooth. So you have to drill in children. And also when you are exposing the lateral mass, the venous bleeding can be profuse in children, and you have to be very strongly, you have to rapidly control the bleeding and get over it. You cannot spend too much time. So that is another thing in children. So it is, this technique has to be, and also the facets are the strongest bones. And in the child, there can be bifid atlas or bifid C2, but the facets are strong. So you can use the facet for screw implantation in children, in young infants. So I can also see Vatsal. Dr. Vatsal, you are there on the screen?
Yeah, sir. I'm very much over here.
Yes, Vatsal, I want to see your face. Why it is not seen?
Sir, it is very difficult to tame the vertebral, but in your hand, it always a easy thing. It appears.
Yeah.
Once I faced the vertebral injury, there was a havoc in my operation theater. But it looks quite safe in your hand.
Difficult, but possible. Difficult, everything is difficult in life.
It is
but everything
possible.
is possible.
I think it is easy and possible in your hand, sir.
Thank you, my dear Vatsal. You know you are my favorite. There is no question.
Okay.
Anybody else wants?
Yeah.
Yeah, Takashi. Yeah.
Go ahead, Takashi. You have a
Yes,
Yeah, thank
question?
you. The wonderful lecture. So anytime I listen to your lecture, so I feel understood and understanding and very informative, and I start learning many things, a lot of things. So every time I study the anatomy and surgical procedure and many things I learn from you. So I keep attending this lecture. Thank you very much.
thank
Very
you.
good.
Thank
Very
you.
good. Dr. Goel, Suhail Aghani has a question. Do you advise cervical collar post-op?
Yeah. I advise cervical collar for at least 2 months and restriction of neck movements for at least 2 months, because this is a very mobile area of the spine. And once you have put your bone graft and your implants, the implant will hold the bone for about 3 weeks. And after 3 weeks, the bone fusion should occur, and bone fusion should hold the implant. So the implant will hold the bone 2 or 3 weeks, and then the bone fusion should occur. So during that 3-4 weeks, we have to restrict the movements of the implant. And I think it is very important to use a cervical collar for at least, I use at least for 2 months, just to be safe.
Okay, well, another question. Deepak Baria asked, where can we experience hands-on training?
you have to catch hold of the patients, and you have to find the right indication. You have to go to the lab, you have to learn the anatomy, and then you have to do a very beautiful operation. Because here, you know what, you cannot say, let me try. You cannot say, okay, I know 95% and then I will learn on the patient. You have to be 100% before you enter into this field. Because the slightest of complication in this field, C1, C2, can be absolute devastation for the patient. So you cannot learn on the patient. You have to be 100% sure that, yes, I can do it, and I can do it absolutely perfectly. Of course, you have to learn as you grow, but you have to be quite sure that you know the technique, you know the implants, you know your instrumentation, you know your drill system, you know your screws before you enter into the business of doing. You cannot go half-hearted. And if you say, let me try on the patient, that may be a wrong kind of thing. You have to be sure before you enter into this.
Okay, someone remarked, or Kumar remarked, there was a hands-on
Abhinav?
cadaver workshop at Samaya Hospital last month.
Yes, I had conducted. Abhinav, you want to say something on the screen?
Sir, I just want to say that, hello, am I audible?
Yes,
Yes.
very much.
Yes, good evening. Good evening, sir.
Good evening.
I just want to say that I have been so long with you and seen so many craniovertebral junction surgeries. And I'm not really sure how people do it or how they don't do it, but I'm damn sure that the kind of cases that you do and the results that you get are very, very difficult to replicate. But yes, with you, everything seems easy. And we hope that I get to do these cases at some point of time in my life. So
Sure, you will
thank you.
definitely do, my dear Abhinav, and my best wishes to you.
Thank you, sir.
Okay, I think that's all the questions. Does anybody else, last chance to ask the king? Okay, great. Thanks a lot,
Okay.
Dr. Goel. A very interactive session. I'm sure everyone learned something, and we look
And
forward to
John, also, I have a feeling now you can do this operation. You have heard me so many
Yeah,
times.
I'm ready to go. So I'm ready to scrub in.
Yeah. Okay, John and everybody, thank you very much for listening.
Thank you.
And this is a very fantastic, C1, C2 is a very common operation, and the indications will increase over the years. And my best wishes to all of you. Bye-bye.
Thank you very much.
Thank you.
See you next week.
Bye.
Yes.
Next week. Thank you.
Right.
Thank
every
you,
week.
Takashi. Bye-bye.
Okay, very good. That was good, huh? Very interactive. Because I know people want to ask him questions. He could go on and on. And one time I had a webinar, there were 2 residents there. And Dr. Goel spent hours answering their question. 2 residents. This is when I was in the PAL with Dr. Sherian. And the first webcast we didn't have many people because it was a new technology a couple of years ago with it was Google Hangout. It wasn't Zoom. Does anybody remember those days? Probably not. Nick, are you there? There's Dr. Anybody else want to say hello to the spine community or ask any questions? I guess